I have the distinct honor and pleasure of introducing Emily Watson. Emily's been a social worker for nearly 20 years. She's worked in various settings, including school, outpatient family practice, infant adoptions, and for the last 15 years has been working in dialysis at Satellite Healthcare. Now, as the director of the social workers services for Satellite, her focus is to support the work of the social workers in meeting the needs of our patient population. Emily has spent time addressing issues related to access to transplant, addressing patient life and health goals, and more recently, understanding more the depths and impacts of social determinants of health in our patient population. On a personal note, Emily is married with 3 children and lives in Santa Cruz Mountains here in California. So with that, I turn it over to Emily.
Thanks, Kathy. I appreciate that. And thank you to all of you who have joined me this afternoon. Welcome. And I know there were choices. You had to pick a session to join. So I appreciate that you're here with me. And I hope that I bring something to your knowledge base, something for you to think about. And thank you for choosing to be with me. So as Kathy said, I'm with Satellite Healthcare, and I'm here to talk to you about, as you've probably guessed from the title, social determinants of health. So first off, I really have nothing to disclose, so we'll move through that. And let's get to the objectives. What I hope for you today from this talk is to walk away with a more clear understanding and definitions for social determinants of health and other related terms such as health equity. And I have found, especially in my research, that the term social determinants of health has become ubiquitous in healthcare, and using that too liberally has led to a loss of focus and impact of the actual work that we do or that we need to do. So I'm hoping to bring some more focus today. Secondly, we're going to review the healthcare field and the larger national stage and what is being done to address these social determinants of health. And lastly, we're not going to walk away without a call to you to look at your space, both personally and professionally, and where you might have a role to make a difference. So thank you again for joining me. Here's our agenda. It's pretty simple. We're going to start with some definitions, move to look at the disparities between where we want to be and where we are, responses to social determinants of health nationally as well as internationally, and then lastly, the impact that we can make. So let's go ahead and start with some definitions. The first one I want to begin with is probably the most obvious, and that is what social determinants of health are. This definition comes directly from the WHO, who are the leading source of information around social determinants of health. More than 5 decades ago, they started the initial work with a global impact, which then led to each nation taking and looking at their own backyard, what was going on. But the definition is social determinants of health are non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, as well as the wider set of forces, systems that shape and condition daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. So you may be wondering if these are non-medical reasons, why are we talking about them here today at the medical symposium? And how do they really affect medical outcomes? So let's talk a little bit about that. I want to share with you this infographic here that is put out by Healthy People 2030. And if you're unfamiliar with that, I'm going to talk a little bit more about that in a few moments. But what I want you to see here in this health graphic is that there are 5 key areas that the social determinants have been bucketed into by most regards. Some look at it in 6 ways, and I'll show you that in a moment. But this is a real simplistic view of where these social determinants impact our lives. So I want you to think as we go through this presentation, for example, a child who might be born to parents who never completed high school and who might be living in an environment that poses some health risks maybe with regard to safety or lack of safety in the neighborhood, exposure to environmental hazards, possibly some toxins in their housing situation along with some substandard housing. I want you to keep that picture in your mind as you think through the life that this child may be exposed to, and wonder why maybe if they have less access to opportunities in their physical setting, such as sidewalks or parks or playgrounds, even a library, how that might impact their health down the road. So let me show you one more infographic that depicts the social determinants of health. As I said, this one has 6, and I'll explain that the 6th is the food column, almost in the middle there. But I want to use this one because it does delineate what falls underneath these different categories. So when we look at economic stability, this one may not be a hard one to imagine. Obviously, income and employment are the main ways that we bring money in that we can then use for our economic stability. However, sometimes we need to consider employment and look at things such as underemployment. This is that term that captures people that are involuntarily part-time employees. You can think about some of those big box stores, right, that only hire those part-time employees as to avoid paying for benefits, right? And one of those benefits being something as important as healthcare, right? This includes maybe poverty wage employment or insecure, maybe migratory work, field work, for example, that is not dependent. It might be intermittent. That's an impact to one's income versus someone that I can say, like myself, that has a regular, steady source of income. I have a stable setting there. When we look at economic stability, it includes being able to pay rent, to find a setting to live that is not dealing with, say, overcrowding or frequent moving, maybe even that couch surfing syndrome that you might see in some of your patients or even folks that you may know. And what I find really interesting here, when you think about the economic stability that rolls over into housing in the next column, is that housing is considered to be a cost burden, and a household is cost burdened if they spend more than 30% of their income on housing. So some of you sitting here in the peninsula or the Bay Area, or even just in a high income, a very high cost of living area, may be surprised to know that it is considered severely cost burden if you spend more than 50% of your income on housing. So it's no wonder that we see people leaving these areas where costs of living are high and subjecting themselves to either lesser paying jobs further out from the big city, or a commute back into the big city to that same job, adding to the burden and the work-life balance. It probably wouldn't surprise you to know that Black and Hispanic households are almost twice as likely as a white household to be cost burdened in this way. This begins to bring into the conversation today the ethnic and racial disparities that we see. That is a big piece of what we're talking about here today. So socioeconomic status here in that first column is determined by a family's income level, their education level, and their occupational status. And when those pieces don't stack up beautifully, you're going to see some impacts to access to healthy lifestyle activities. So when we look at the neighborhood and the physical environment, first of all, you can think about housing and quality of housing, right? Did you know that when you look at neighborhoods and the built environment, one of the things we don't possibly think about is how close we live to a supermarket. I'm fortunate enough to know that with a really good, with a rock, I can hit probably 2 supermarkets from my house. And with a really good throw, I could probably hit a 3rd one. And so the availability of food to me is not of a concern. And when I looked into more of this research, I found that the average distance here in the United States as of 2013 said that the nearest supermarkets on average were 2.2 miles away. Now that may not sound like a big distance if you can hop in your own car and drive there at any time, probably 24 hours a day, and access food and make some healthy food choices. But if a car is not at your disposal and you had to, say, walk or bike that 2.2 miles to get to your grocery store, that might be an impediment. And it might be easier to go to that gas station that is actually maybe a skip of a pebble from my house, that I could get some more easily packaged fast food that would be a less nutritious choice. And that might be what we see happening in many of these neighborhoods. There was a study that was done in Detroit that found people living in predominantly low-income Black neighborhoods were traveling an average of 1.1 miles farther to the closest supermarket than people living in a predominantly white low-income neighborhood. So again, another underscore of some of these racial disparities that exist in our communities. Part of the physical environment also is exposure to the top 3 environmental conditions that negatively impact health and population health, which are polluted air, contaminated water, and extreme heat. Let's think about the storms and the weather that we've been up against in the last many recent years. We can think back to Flint, Michigan, and the contaminated water there. These are realities in our own backyard. These are not third world issues that remain outside of the United States. That is, a developed country. We struggle with all of these issues, even in our own backyards. When you think again about neighborhoods, we think about zip code here. Again, part of my title was looking at the geography and zip code and how much more this might play a role in one's health over their genetic code. So walkability, if you think about somebody who's looking to possibly, say, lose some weight, and one of the best things to do would be to get outside and do some more walking. How easy is that to do if you don't have sidewalks, or if you're not in a neighborhood that's actually safe to be out and about and walking around? These are issues that are in the neighborhood that can't be fixed in any one simple, easy way, that require a more systemic, broader application of support. Education. We know that education starts, the benefits of education start in early childhood. The first 5 years of life are really, really important and have long-lasting social and cognitive as well as emotional benefits into life. We know that high school dropout rates, conversely, can affect health impacts, meaning the lower your high school completion rate, the more negative the health impacts of that community may be. We know that not having a high school diploma is going to limit employment prospects. It's possibly going to lead to low wages for a lifetime and may even end up in poverty. So just looking at high school completion rates can be a sign of the social determinants that exist in a certain area or neighborhood. The access to and utilization of vocational training or higher education is another indicator of ability for individuals or community to better their life situation, their life standing. And literacy and language play a role here for sure. When we look at language, we look at access to the information that one needs, right, to be able to make choices in their life. And if you live in a community that may have non-English speakers, how well does that community address that population? How much is information offered in a language that people can understand? I think more and more we see certain things changing. You know I get my utility bills with multiple languages listed or ways for folks in different languages to access information. And these are newer. These are things that didn't exist maybe 20 years ago. So we are moving in the right direction, and yet there's still a ways to go. So again, food here, hunger falls under maybe that economic stability, being able to afford that next meal and buy those groceries. Access to healthy options really can relate to that neighborhood and the food desert that you might experience when grocery stores aren't in a reasonable distance to be able to make healthy food choices. Community and social context is looking at civic participation, for example, and community engagement. This encompasses all kinds of activities, including voting and volunteering, maybe even participating in group activities, such as, say, community gardening, right? That one's going to have a wonderful benefit broader than just for that individual. It's going to bring benefits of healthy foods, fruits and vegetables, possibly to the community that may have been lacking before. But we know that even considering what Carol Tassoni was telling us earlier about social connection and how important that is to social and emotional health, that just being part of a group can improve health. For many of us, and we can probably reflect back on our own experience over the last 18, 19 months, what kind of connections we have or have been lacking that has helped our social and emotional health. In our social and community context, part of that is, part of the impact here is discrimination. There's no way around the fact that discrimination exists, that it is actually a social structure. It leads to unfair and unjustified harms to individuals and even groups. But discrimination is, when we think about it, it is a set of social interactions or rules or policies or terms that occur to protect the more powerful and privileged groups to the detriment of others, right? And these need to be addressed, but they can't always be addressed by an individual. And we need different ways to work at destabilizing discriminatory actions. Healthcare system, finally, all of us are very, very familiar with the healthcare situation, and we know that there are many barriers to healthcare, and one of the biggest barriers is access to insurance. And we just heard Dr. Cervantes talk about access to healthcare being a major barrier, and that up to 18%, I believe she said, of Latinx people in her study or in her work were uninsured. This is a huge barrier because we know that without health insurance, attending a primary care appointment, a preventative care appointment is not going to happen. Primary care is so key to early detection of diseases, to management of chronic diseases, and to preventative care. We know that children without health insurance are less likely to be vaccinated and puts them in a situation that are more vulnerable to disease and exposure. We know that overall having health insurance increases the use of health services and therefore improves and impacts health outcomes. Some obstacles to health insurance, as we also heard Dr. Cervantes talk about, was information in language that could be understood. And in addition to this, health literacy is a special kind of literacy that I'm very interested in and passionate about. But health literacy is not about the reading and the writing and the material in front of you. It is about the degree to which an individual has the capacity to obtain and process information based on their basic health needs and to make appropriate decisions, whether it be for themselves or for their family. And so health literacy is really a big part of our healthcare system, and being able to provide quality care really means making sure our patients understand what's in front of them. So it may not now surprise you to know that social determinants of health can account for up to 55% of health outcomes. Now, that may solidify your understanding, or that may shock you. But I want to continue to talk about what can be done and what the importance of knowing this is. Health equity is, as defined by the World Health Organization, it is the absence of unfair and avoidable or remediable differences in health among population groups defined socially, economically, demographically, or geographically. That sounds like a really tall order. However, knowing that there are trends in the work that we do in the environments we are in that are unfair and unjust, that lead to differences based on a decision-making process or a policy that's in place or a social norm that has yet to be corrected or a structure that is in place inappropriately so, leads us to feel that there is work we can do and it's within our reach. So pursuing health equity means striving for the highest possible standard of health for all people. And yet it also means giving special attention to the needs of those who are at the greatest risk for poor health based on their social conditions. So sometimes it means sort of checking and acknowledging your own privilege. This is a simple infographic that you may have seen. There are many like this out there. The top row shows you what equity looks like. Every person in this picture is on a bike, and yet the bike suits their individual needs. Down at the bottom, we see equality, where many systems nowadays still focus on equality. Let's give everybody the same, everybody gets the same bike. So you see the child can't reach the pedals, the tall person can't quite fit on the bike, and the person in the wheelchair can't use a two-wheeled bike. So that's what equality is. When we strive for equity, we need to recognize the special needs that exist. Here's another depiction. I like this one as well because it goes a step further. Again, equality on the left, everybody's got a box to stand on, still doesn't meet everybody's needs. So when we address the special needs of everybody in that picture and move a second box under the short person, I'm assuming is a child, now everybody has an equal view based on the equity of distribution of those resources. Now, if we take it one step further, without adding special supports, if we change the barrier, physically here it's a fence, we change the barrier, we now have overcome that systemic barrier, and that would be social justice. So part of the definitions that I want you to walk away with today is understanding the difference between individual and community level impacts of interventions that may or may not address social determinants of health, because understanding those will help you with your personal work towards recognizing language that we use and interventions that we put in place and what they're simply addressing. So social needs, this is an individual need based on the individual circumstances. This might be, if we look at our dialysis setting, the patient who walks in and says to you, listen, I spent all my money on my car repairs and I don't have money for the rest of the month to buy food. What can you give me, say to me, provide me with? And we are in a wonderful setting in dialysis where we have social workers on site. And this is where a lot of social workers spend time, is addressing the individual social needs in the moment, providing maybe a resource to a food bank, maybe even a bag of groceries that might even be available in the center. And certainly working with a dietitian to say, look at what this patient is facing. Can you help address these nutritional needs as well? Then you have your social risk factors. These are the factors that exist just below the surface that you don't know about until or unless you ask. Again, this is a realm that I know our social workers and even our dietitians spend a lot of time learning about through our assessments and talking with our patients and understanding their situations better. The social risk factor might be that a patient is living paycheck to paycheck. And in that previous case, when they needed to spend money on the car, and they didn't have enough money for the rest of food for the month, this is their risk factor, that they are moments away from another potential tragedy, whether that be being out of food again, or being without a home, being without a car, being without a job. And so the social risk factors are what exist on an ongoing basis. And I wanted to bring in here behavioral factors, because I think this is important. These are individual behaviors that impact health. Some of them are things like smoking or alcohol intake, maybe even substance use, lack of exercise, food choices. And one might bring in some judgment here and say, well, if you make a bad choice or if you choose these activities, you're impacting your health, and it's all within your control. And I want to caution all of us to bring empathy and bring compassion to the work we do with our patients. Think about somebody who might be overweight, right? Who wants to, again, lose weight and can't get out of their neighborhood to go for a walk, certainly don't have the extra funds to be a part of a gym, live in a food desert where affording those more appropriate, healthy food choices is not an option. The situation they live in is more than just the choice of the food that they're eating. It is based on the circumstances that they are surrounded by. So again, conflating behavioral and social risk factors can lead to short-sighted approaches that focus a little bit too heavily on the individual behavior and not on the systematic or systemic or environmental concerns. Also want to be really clear that behavioral factors is not in this context talking about mental health and mental health risks, which is in of itself another set of issues that we're not going to be discussing today. So here's a quick poll done by the Robert Johnson Foundation that talked to primary care physicians and pediatricians, and 85% of them, yes, agree that dealing with social needs is as or more important than dealing with medical conditions. Hands down, when a patient walks in and says to you, I don't have food to eat, I don't have a roof over my head, I don't have transportation to my next appointment, yes, dealing with those are important, and I think everybody sees that as important. And yet, sometimes dealing with that in the moment is still not addressing the underlying structure that is causing the problem. So now let's talk about those community level definitions and how those might impact the work that we do and how we look at social determinants. Well, population health is just that. It is the health outcomes of a group. It's looking at even the distribution of the outcomes within a group. We can do things like look at data from large clearinghouses to understand what's going on in certain populations and make decisions about policies that may positively affect that same group that might be suffering from some kind of exposure or increased prevalence of a disease. We can look at structural factors, which are public policies, things that exist in our country like macroeconomic policy, policies on education or housing, even Social Security, and broadening these to be more inclusive, but to be more supportive, again, of those who have more need. But we need to change at a larger level, not at the individual level. And then the systemic issues. These are things like systemic racism, like the determinants of health that are impacted by the long-standing historical factors, policies that exist that are bigger than any one individual and may carry through generation to generation, and that need to be addressed head-on and face first. So when we look at social determinants of health, I have a question for you. Just think real quickly, what's your answer? Are social determinants of health inherently positive or negative? You know, when I first started learning about social determinants of health, it was maybe 6 years ago that this term became a part of my lexicon. And when I first heard it, I thought, that's what I do every day. I'm a social worker. I address these social determinants of health. And in my research, I realized I have addressed social needs. I have addressed social risk factors for the individuals that I work with. And spending the time looking at the fact that social determinants of health really need to be adjusted at the community or the larger level has led me to realize that we use this term in a very negative way. We use this term as, you know, if somebody has not enough funds to get through the month or doesn't have transportation, say, to their dialysis center, that it must be social determinants of health. And certainly those are most likely at play. But using our lexicon appropriately, we can better understand that social determinants of health are at play for everybody. They impact everybody. It's just a level of, is it a positive impact or a negative impact? You know, and I reflect on my own life, and I recognize I came from a family where both of my parents had, you know, postgraduate education and made good livings, and then enough so that my mother stayed home to raise me and my brothers. And then I was encouraged to go to school, and I did postgraduate work, and I got myself a job that provides financial stability to me and healthcare insurance that gives me access to health and has led to a lot of where my health is today, the ability to care for myself. So I think recognizing that social determinants of health are not a positive or a negative, they are a presence and they are part of everybody's life. So let's move on in our agenda to disparity. I think we know that there's a lot to be done, so let's take a look in our own backyard. Here, the U.S. healthcare consumption per capita, you can see that it is double what is compared to other countries, just like us. Other wealthy, developed countries, we spend over $10,000 per capita as opposed to the average of $5,000. So if we're spending more, would it lead you to believe that we do better? Well, let's keep looking. Here we have total health consumption as a part of GDP. So again, the top green bar is the US. We spend 16% of our GDP on healthcare. That is the money that we put out. That's a percentage of GDP on healthcare. That's a lot, because on average, it's about 10% for other countries, again, just like us. In the blue column, you recognize this is the amount of money that countries put towards social services and programs that support folks outside of the healthcare setting, but social programming. And here the United States spends, yes, a little bit more than the rest, but not a lot more, not at the same rate that we spend on the healthcare consumption. And so again, are we doing better? Here's just another depiction of how much of the GDP that the United States spends on healthcare consumption. You see the US is up in the top little green dot, and it's way outside of the norm that we see as that trajectory. Here we come to healthcare access and the quality of the healthcare. Now in this table, this is looking at mortality based on amenable diseases, rates or causes of death that are preventable. There are 32 diseases that they look at, or causes of death that they look at that can be preventable. And so here, the higher number is a better number. And you see the percentage of preventable deaths that are prevented. The United States falls short. We are last in line here against other comparable countries. Again, far below the comparable average. And we see this in settings like this. Here we have maternal mortality rates in the US. We are seeing them over the last 30 years. This trend is a 30-year trend. Increase from just over 6-7% to over 20% in 2018. Whereas comparable countries are actually showing an average of a decline from just over 5% or about 7%, sorry, to just over 5%. So again, all of that healthcare consumption and the dollars going towards healthcare is not quite panning out yet. This one I included because I think when we think about human rights, access to internet is now top of mind as possibly a new human right, that the access to what we use every day, all day, what we're using right now is the internet. And this was done actually in 2019 before the pandemic. And you see the two blue sections of this circle are our Medicaid and Medicare patient populations that report not having access to the internet. So Medicare and Medicaid patients, 2/3 of patients without internet access are Medicare and Medicaid patients. Think about what we just went through the last 2 years. We just asked many of these patients to get online, visit their physicians by telehealth, visit their families and that social connection by internet connection, by FaceTime, by Zoom, maybe even mental health. Ask them to do their mental health using an internet connection. And imagine how limiting that must have been. So let's move on to responses and talk about who cares. Who does care about this? Well, obviously the World Health Organization, who really was the impetus behind this movement that again started 5 decades ago. But we see many of these organizations exist here in the United States. And for example, the Healthy People 2030 is what I wanted to talk with you about, where a lot of this information comes from. This is the 5th edition of the Healthy People initiative. It began back in 1979 with the Surgeon General releasing a report that focused on reducing preventable death and injury. He set up a bunch of really ambitious and quantifiable objectives to achieve in about 10 years. And by 1990, when they realized, wow, there's still work to do, they created later decades of this report and initiatives. And we have seen now multiple iterations in 10-year categories. We've seen Healthy People 2000, Healthy People 2010, Healthy People 2020, and we're now moving in Healthy People 2030. I found it quite remarkable to know that Healthy People 2030 actually decreased the number of measurable objectives they are looking at down to 355. And that is less than what we've seen in past years. These are both developmental and research objectives, so really looking at potentially what else needs to be understood before we can make it a solid objective. But if you're interested, you can go to healthypeople.gov to find out more about the work that is being done here. So I wanted to share this with you because when we think about the work that is being done and we think about the efforts that are being made, part of it is understanding the role that you have. And I love this ad. And I thought, wow, I would love to see more of this in the United States. This comes out of Canada, but this starts off by saying not everyone has an equal opportunity to be healthy. Family physicians can help, and let's find out how. And they talk about here, social determinants of health is the best way for family physicians to know more about the communities they work in. How wonderful would that be? Here is Health in All Policies. It's a collaborative approach. It's a term and a collaborative approach to integrate and articulate health considerations into policy making across sectors and to improve the health of all communities and people. This is from the United States and what we're working on to increase the number of Americans who are healthy at every stage of life. This is a whole interactive program that is actually sponsored by and run by the CDC. And there's an amazing resource center. If you have interest in understanding more about this, I recommend taking a look at the CDC website and Health in All Policies. This again is more the infographic here I really loved. It's quite descriptive of how impactful and how broad the work is that needs to be done when we look at Health in All Policies. Across the top, I know it may be hard to see from where you are, but this is dealing with air pollution and exposure. This was put out by the World Health Organization, but needing to include all sectors such as healthcare, transport, housing, work, nutrition, sanitation, and all of that. And you can follow this infographic in this winding path at the bottom that talks about how to create clean energy, how to address it, pollution through housing and through our own cooking standards, how to look at the industry. So many of you may have started off thinking, oh, let's go straight to the cars and straight to the smokestacks. But there's so much more here. You have to think about your urban planning, right? Are people driving around because there are no sidewalks or bike paths because things are too far or too different? I mean, distant from where they live to be able to manage with low emissions or no emissions? What about waste management? And what about our local authorities? What are they doing to follow this? And following up by health ministry, who's tracking the effects of the work that we do? So I find this quite impactful, and I really love that infographic. So let's wrap up with impact. Here we see an idea of how a comprehensive view of public health strategy, looking specifically at our industry, at kidney disease, might look. We need to bring awareness, a public awareness to the work that we do and the prevalence of kidney disease. We need to bring more patient education and support, and we need to do that from an individual level and from a policy level, right? We need to use that data mining like I was talking about before, where we can understand population health and get a better sense of where our needs are where our interventions are needed most and how to best address those. Again, we don't want to give somebody a fish for a day. We want to teach them how to fish. We want to fix the whole situation so that the problem can be ameliorated going forward. What about addressing disparities and recognizing that, again, different cultures, different ethnic and racial backgrounds are discriminated against, are disproportionately affected by our kidney disease prevalence. And then lastly, COVID-19. We just heard a lovely talk from Dr. Cervantes and Carol Tassoni about COVID-19 and the impacts that we have there that have brought on more acute kidney injury. And that may mean we may have a larger population of end-stage renal disease patients down the road if we don't intervene soon enough. So developing a comprehensive strategy is in front of us, and we can all take a part of this. So I think this is a sign you've been looking for, the end of my presentation. Again, I thank you for being here, and this is my call to you to consider what have been the determinants in your health and what have been the positive or possibly negative determinants. Then I want you to reflect on the patients that you work with and what have been some of the determinants that have impacted their lives, possibly bringing them to become your patient. Lastly, look at the policies that you can recognize and that you see that impact social determinants of health from your experience. And then where can you make a difference? So I'll end here, and I welcome any questions, but more than anything, I thank you for your time, which is precious, and I appreciate you being with me today.
Thank you, Emily. Great presentation. Really got me thinking about the patients that I've served over the years and what I could have maybe done differently. Just a reminder to people, if you have questions, to go ahead and put them in the chat. Lots of thank yous here. Are there any immediate interventions that can be undertaken by the dialysis providers or workers in the field now to address these social determinants of health? Any specific examples?
Yeah, I think, as I mentioned, being a social worker from the dialysis center, I know that we are able to address those social needs in the moment. We're able to understand maybe the risk factors of our patients, and we can address those in short form, and it will assist that patient for that time, for that moment. But if we want to make a difference from where we stand, where we sit, where we work, I think it means understanding, taking a look at your own policies, maybe for the center that you work in, maybe for the community that you live in, maybe for the state that you live. Where do you find an affinity to a policy that doesn't fit right, or an issue that needs some support? I was so pleased to hear Dr. Cervantes is working on the unfunded Latinx population and working towards finding undocumented support for transplant. She's working out of Denver, but for working with UNOS to make a difference there is a huge step in the right direction, as we all know. I think understanding, even within your own building, when you look at policies in your center, does your center support working patients? Do you offer shifts that allow for patients to come in and work around literally their work so that their livelihood is not as negatively impacted by being on dialysis? I know at Satellite we do that and we take a priority there, but that's an example of looking at the policies that impact your exact setting, as well as looking broadly to organizations like the National Kidney Foundation and others and the work that they do. So I do think, depending on your interest level, your comfort level, and your exposure, finding that niche is the way you can go about that.
Okay, great. Luna says, I think this brings to mind how we interact with our patients, the need to act with compassion and understanding. So thank you so much. Lots of congratulatory, great job, excellent slides, presentations that have been commented in the comments. Not seeing any other questions. Is there any? Go ahead and put them in the chat if you have any other questions. Okay, I'm not seeing anything else come in.
It's all right. It's about time to, I think, heading off to the next section. So again, thank you for being here. Thank you for the support, but certainly enjoy the rest of the day today. There's been some wonderful talks so far, so I can only expect more of the same.